Ladies and gentlemen, welcome to today's webinar, and thank you for joining us on such a beautiful day in the UK. Today's webinar, the first part is on vaccines and multiple sclerosis, current guidelines and considerations for 2025. My name is David. I'm a consultant neurologist from Sheffield. And to join me today, I have two exceptional speakers that I think will be able to really enlighten us on this topic. First up is Saul. So Saul is actually a neurologist from Colombia, where he works at the Fundación Santa Fe de Bogota, but he sort of spans continents. He came to the UK for an ECTRIMS fellowship in 2018. So he's well aware of some of the difficulties and challenges that we have in the UK, and he is uniquely primed to help us really work out how we're going to integrate vaccine strategy into our care of people with multiple sclerosis. Secondly, I have Joella. Joella will be known to, I imagine, most people on this call, but Joella is a neurosciences pharmacist at Barts in London, which in turn is the largest NHS trust in London. And it's a job that she's done for almost 20 years. She has thought extensively about UK MS policy and how to integrate that. And together we're going to try and help ourselves and you understand the roles of vaccines in multiple sclerosis. Just to let you know, the Neurology Academy is always innovating, and we've recently produced this health and wellness on-demand course to try and help support yourself and your patients to live their best life. So I'd really encourage you to check that out. It's really, really good. Our webinar receives sponsorship from Novartis. I'm incredibly grateful to them for their sponsorship, but this is a non-promotional session. The objectives of today's talk is to understand the role of vaccines in MS care, review our current guidance, look at how we time vaccines around disease-modifying therapies, addressing some of the concerns and misconceptions that people have. And also a really important part is working with our patients, how we communicate and educate them about vaccines. So without further ado, I'd like to introduce Saul to give his talk.
Okay. Thank you, David, for the introduction. Hello, everyone. My name is Saul Reyes. I am a neurologist, and as David mentioned, I am currently based in Colombia. My main focus is multiple sclerosis, and within MS, I am particularly interested in topics such as vaccination in people with MS, which is what we will be discussing today. Thank you to the MS Academy for the invitation, and thank you all for joining us. These are my disclosures. So vaccines have had a huge impact on the rate of cases of some vaccine-preventable infections in England. And these are just a few examples. And as of today, it is quite clear that vaccines have greatly reduced the threat of these infections. And there is no doubt that vaccination is one of the most cost-effective tools for preventing these costly and potentially life-threatening infections. And although worldwide vaccination coverage for the most important vaccines that are routinely given to children has increased substantially over time, the rates of vaccination are still not as sufficient, especially during the last few years when as you all know, the COVID-19 pandemic interrupted routine vaccination for millions of children worldwide. And now immunization coverage is worryingly below 75% for many vaccines. And at the same time, we have seen a rise in vaccine-preventable infections all over the world, especially in areas like South America, Africa, and Asia, but also in Europe, North America, and the UK. A very illustrative example of this situation is measles. For instance, in 2024, there have been more than 2,600 confirmed cases of measles in England. And low uptake of the measles vaccine seems to be the key driver. And although the majority of these cases were in children, more than 30% were in young people and adults aged 15 years and older. This, for example, is relevant for adult patients with multiple sclerosis who have not been vaccinated against these viruses, because they remain at risk of getting these infections, which are becoming more and more common in different parts of the world. So that was immunization coverage data for children. But what about adults? Here are some vaccines recommended for adults. Some of them are especially targeted to adults in certain age groups, and also to adults with some specific underlying medical conditions, like the influenza and the BCG vaccines. And the problem is that immunization coverage in adults in clinical risk groups remain low for most of these vaccines. So according to the UK Health Security Agency, the influenza vaccination coverage for the latest winter season in young individuals within clinical risk groups, which of course include people with chronic conditions like MS, is suboptimal, and is only 43% in those with neurological conditions. And then for shingles, only 17% of immunosuppressed patients who were eligible for this vaccine actually receive it. So it is clear that vaccination coverage remains a challenge, not only among children, but also among adults and older people. And why should we and our patients with MS care about this? There are many reasons. Two key reasons are: number one, people with multiple sclerosis exposed to immunosuppressive therapies or those with greater disability are not only more susceptible to infections, but also at an increased risk of both morbidity and mortality from many vaccine-preventable infections. And number two, infections have been associated with MS exacerbations that may lead to more severe and sustained disability than spontaneous relapses. So we definitely don't want our patients with MS to get these infections, especially when they are considering immunosuppressive therapies. So having said that, let's dive into the topic, and let's talk about vaccination and multiple sclerosis. And this is the very first question that we need to answer. So are vaccines really associated with the onset or relapse of MS? And we have to address that there are some historical observations of post-vaccination encephalomyelitis and a few case reports of MS developing after hepatitis B vaccination back in the 90s. But in the last 2 to 3 decades, many studies have failed to show any causal link between vaccination and the onset or relapse of MS. So the available evidence, the best available evidence, suggests that there is no increase in the risk of developing MS following these vaccines. Hepatitis B, HPV, influenza, tetanus, diphtheria, pertussis, polio, BCG, typhoid, or MMR. And actually, for those with the star sign, HPV, tetanus, pertussis, and BCG vaccinations, they might be associated with a lower chance of a subsequent diagnosis of MS. And regarding disease activity, vaccines against hepatitis B, tetanus, tick-borne encephalitis, influenza, or yellow fever do not increase the risk of relapses in patients with multiple sclerosis. Now let's explore the recommended vaccines for people with multiple sclerosis. And first, we have some general principles that I want you to keep in mind. So in patients with multiple sclerosis, the benefits of most vaccines greatly outweigh any potential risks. People with multiple sclerosis should be capable of mounting an immune response to vaccines in a way that is similar to individuals without MS, as long as they are not yet receiving any immunotherapy. And as last but not least, the vaccination schedule of people with MS should be verified and updated as soon as possible after the diagnosis is suspected, to prevent any future delays in the initiation of disease-modifying therapies. Now I'd like to share with you some specific recommendations, and they are from three key sources, which I believe are very relevant for your practice in the UK. So the first one is this paper on the left that we published with the Barcelona team and Public Health England. And then we have this ECTRIMS consensus that we published a few years ago. And also, I would like to highlight some recommendation from the most up-to-date version of the Green Book. Okay, so first, we recommend influenza vaccination with the inactivated vaccine for all patients with multiple sclerosis, their relatives, and also their carers, especially for pregnant women with MS and older patients. And this vaccine is available each year and is giving us a single dose. Then we have the pneumococcal vaccine, which is recommended for people with multiple sclerosis at high risk of pneumococcal disease, which includes all patients who anticipate long-term immunosuppression, those patients with compromised pulmonary function or high levels of disability who are at high risk of aspiration, and then also patients aged 65 years and over. We use the PPV 23 vaccine, which is also giving us, which is also inactivated and is also giving us a single dose. Okay. So VCV vaccination is particularly relevant for patients who are starting immunosuppressive therapies because herpes virus infections are more common and more severe among these patients. So the recommendation is a full course of varicella vaccination for people with multiple sclerosis who are susceptible to primary VCV infection. So that'll be people with MS without a confirmed history of chickenpox or without documentation of a full course of vaccination against VCV. They should be tested for VCV antibodies, and if negative, they should be offered the VCV vaccine. So adults should receive 2 doses at least 4 weeks apart. And as this is a live vaccine, it should not be given to patients who are already on an immunosuppressive disease modifying therapy. And then we also have the shingles vaccine for preventing herpes zoster and postherpetic neuralgia in older people. And now in the UK, you have a new immunization program, which is this one you have here in the orange box. Where Shingrix, which is the recombinant vaccine, is given to patients older than 65 years, but also to those older than 50 who are immunosuppressed. You can even offer it to younger patients receiving DMTs if they are at a high risk of herpes infection, like someone with lymphopenia, but this will be outside the immunization programs. Shingrix is also giving us 2 doses separated by 2 months. MMR. So as adults who missed 1 MMR vaccination when they were younger may not be immune to measles. All patients with our reliable history of appropriate immunization, which means having received 2 doses of MMR, they should be tested for measles and rubella antibodies. And if the results are suggesting complete immunity, we recommend a full course of MMR vaccination before initiating disease-modifying therapies. And this will be 2 doses of the vaccine given 4 weeks apart. Next, we have the HPV vaccine, which is usually offered to patients younger than 15 years old because the vaccine is more effective when it is given before the patient gets the natural HPV infection. However, vaccinating people older and those who have already been infected may also reduce their chances of developing cancer, and you may offer it to people outside the immunization program in terms of the age cutoff. We use Gardasil 9, which used to be given in the past as a 3-dose schedule, but it recently changed to either 1 or 2 doses schedule. And this is simply because recent evidence has shown that 1 dose is just as effective as 2 doses. So the vaccine should be given as per your immunization program in the UK, which is this one here in the orange box. But it can also be considered in patients with MS who will receive immunosuppressive disease-modifying therapies regardless of age. and also for those who are already immunosuppressed at the time of vaccination, but they need to use 3 doses of the vaccine. Hepatitis B vaccination is recommended for at-risk patients with multiple sclerosis, such as those at risk of sexual exposure, patients on dialysis, drug users, healthcare professionals, and patients with hepatitis C, HIV, and also liver or kidney disease and solid organ transplantation. But especially for people with MS who are eligible for anti-CD20 therapies. However, and this is very important, not being protected against hepatitis B is not a contraindication to start patients on these therapies. The reason why you test those patients is to rule out a chronic infection, which will be the real contraindication. So the hepatitis B vaccine is inactivated vaccine, and it can be given depending on the specific product as 2 doses separated by 1 more month, or it can also be given using the regular schedule, which is 1 dose at 0, 1, and 6 months. In terms of COVID-19 vaccination, we recommend vaccination for all patients with multiple sclerosis, but especially older patients and pregnant women with MS, even if they are on anti-CD20s and S1P receptor modulators that during the pandemic shown to impair humoral immune responses to this vaccine. So both primary vaccination schedule against COVID and boosters are encouraged as per your immunization program. And then we also have some suggested vaccines for pregnant women with multiple sclerosis. They should be routinely offered the inactivated pertussis vaccine, which is given as a single dose from as early as 16 weeks of pregnancy, and it should be repeated during every pregnancy. We already talked about influenza. But basically, women with multiple sclerosis who are pregnant during the influenza season should be offered this vaccine, which is inactivated, and it is safe at any stage of pregnancy. So last but not least, we have the respiratory syncytial virus, which is one of the common viruses that cause colds in winter, but infants and older people can develop a more severe form of the disease, such as pneumonia. And after decades of work, a few vaccines against this virus have finally been approved, and many countries are now rolling out new vaccination programs against this virus. That's why in the UK, a new vaccination program was introduced from September 2024. So in this program, pregnant women who are at least 28 weeks pregnant, and also older adults aged 75 to 79-year-old will be offered a single dose of the vaccine. These are currently the currently two licensed RSV vaccines in the UK, and both are inactivated vaccines and given as single doses. So that was a quick guide to immunization for adult patients with multiple sclerosis, but we still need to discuss some special considerations for people with multiple sclerosis who are receiving disease-modifying therapies or are about to start these treatments. And this is extremely relevant nowadays because the therapeutic armamentarium for multiple sclerosis has expanded from only 4 or 5 drugs in 2000 to more than 20 options today, and it continues to grow. And although there are no major concerns about vaccination in people with MS treated with first-line injectable therapies, this is not the case with some of the newer and highly effective disease-modifying therapies. I have to warn you, we don't have much evidence on the safety and efficacy of vaccines in people with multiple sclerosis receiving immunotherapies. Most of the available studies are small and mainly looking at the immune responses to inactivated vaccines. However, the available evidence plus the accumulated evidence from studies during the pandemic allow us to draw some general conclusions, which are here. So in terms of safety, inactivated vaccines can be safely used in MS patients receiving disease-modifying therapies. And live attenuated vaccines can be safely used in patients without DMTs or in those receiving immunomodulatory treatments such as interferons or glatiramer acetate, but they should be avoided in patients receiving immunosuppressants. In terms of efficacy, in MS patients without disease-modifying therapies or those receiving interferons and glatiramer acetate, the achieved protection after vaccination is similar to the general population. Next, most people are receiving DMF, dimethyl fumarate, teriflunomide, natalizumab, and cladribine. They achieve sufficient seroprotection after vaccination. And for patients receiving S1P receptor modulator and anti-CD20s, the achieved seroprotection after vaccination can be reduced. And this was also confirmed during the pandemic with the COVID-19 vaccine. There are limited data on the protection after vaccination in people with multiple sclerosis treated with alemtuzumab, but it seems that vaccination too early within 6 months of treatment may result in a smaller proportion of responders. Okay, so how about timing for vaccination? And as a general rule, when vaccination is required, inactivated vaccines should ideally be given at least 2 weeks prior to the initiation of disease-modifying therapies. And live vaccines are not recommended within 4 weeks prior to starting disease-modifying therapies. The only exception might be alemtuzumab, for which the label recommends against the use of live vaccines within 6 weeks prior to treatment initiation. Then, during immunosuppression, response to vaccines can be diminished, and live attenuated vaccines should not be offered to patients on immunosuppressants. And after stopping immunosuppressants, there are some precautions that we need to keep in mind before administering live vaccines. And here they are. So these are the recommended safety intervals between stopping disease-modifying therapies and the administration of live vaccines. After stopping dimethyl fumarate, for instance, you can give live vaccines only when lymphocyte counts are above 800. For teriflunomide, its long half-life should be considered unless the patient undergoes the accelerated elimination procedure. After stopping S1P receptor modulators, you have to wait between 2 weeks to 2 months before considering live vaccines. And then for natalizumab, the recommendation is to wait at least 3 months. This is for natalizumab, this is changing. For anti-CD20s, for anti-CD20 therapies, live vaccines cannot be administered until B cell counts have fully recovered. And for the immune reconstitution therapies, vaccination, especially with live vaccines, will be safe and effective after immune reconstitution has occurred and lymphocyte counts are back to normal. And this is breaking news. We know that the use of live vaccines has not been studied in patients with multiple sclerosis on immunosuppressive therapies, and they are not recommending during immunosuppression, as I mentioned a few slides before, because there are concerns about their safety due to a potential risk of vaccine-associated infections. So aiming to fill this gap, these two groups published this case series of people with multiple sclerosis on natalizumab who received the VCV vaccine, a live vaccine, and remarkably, no major safety concerns of any kind were reported. Only one patient developed mild chickenpox infection. Actually, for the one here at the top, there's an extension that has just been published last month, including now 88 or 89 patients, and confirming the original results. And these results are very important because they are paving the way for immunization with live vaccines in some selected patients with multiple sclerosis on highly effective disease-modifying therapies. And what this is telling us is that maybe natalizumab and other highly effective DMTs may offer a good balance between providing a high efficacy therapy while mitigating the potential risk of immunization with live vaccines. Finally, our traveling patients may be at risk for many vaccine-preventable infections that are uncommon where they live. These patients should undergo a risk assessment and receive guidance on vaccination from any healthcare professional, or but ideally from an specialist at a travel clinic. And this should occur ideally 6 to 8 weeks before traveling, just in case any vaccination is required before traveling. And of course, the same safety and efficacy principles that we have already reviewed throughout the presentation apply for these vaccines as for the other vaccines we have already discussed. So I will not get into each vaccine because that will be another presentation on its own. But I do want to make you aware that there are several reliable sources where you can find information on travel vaccines, such as the Green Book and the WHO website. Both are open access and very up to date. So I hope I have cleared some of your doubts about vaccination and multiple sclerosis. And my main take-home message to you is that reviewing and updating immunizations should be an integral part of the routine care of patients with multiple sclerosis, and that we have never been better prepared to ensure proper immunization for patients with multiple sclerosis. Thank you very much. And here are my email addresses if you'd like to reach out with any questions or comments.
Thank you so much, Sal. As promised, that was an extraordinary review of what we have to do. Ladies and gentlemen, we've got till we've got about 12 minutes to issue all the questions that we want to Sal. I forgot to tell you earlier, but the way in which you can ask questions, and I encourage you, we can get through lots of questions. So I'd encourage you just to look at the bottom of your screen. There's a box for Q&A, and just type your questions in there. So I'll make a start with some of the things that are coming up already. So our first attendee says that I'm increasingly seeing patients with a history of MMR vaccine with equivocal rubella IgG, but positive measles IgG prior to starting treatment. Would you revaccinate in this situation? And they make the point that this is, of course, more relevant in young women with plans for pregnancy. So they've had a history of MMR vaccine, but their rubella IgG is equivocal, but their measles IgG is positive. The hard question to start with.
Yeah, I'm not aware of any issues regarding rubella serology because they have good immune correlates of protection. The only issue will be for mumps. That's why we don't test mumps. We normally test only measles and rubella because mumps serology testing is not very useful. There are no good immune correlates of protection. So it will depend basically on the. I wouldn't go with the results of the serology. I will mainly focus on the local situation. If there is any increase of cases like locally, I will consider the measles vaccine. But if the patient is positive for measles vaccine, I wouldn't offer the vaccine.
Perfect. So yeah, they're positive for measles, but the rubella is equivocal. But I suppose you're saying that there's a correlation between the two, and we've got that vaccine history. We're comfortable with that. I think I'd agree with Gigi, Ella. I think that person has been vaccinated, haven't they?
Yeah. I think it's speaking to your virologist before you get these patients and having a consensus, saying, "Look, if we get these results that are like this, what do you want us to do?"
Yes.
Because, opening those lines of discussion are often useful.
Yeah, that's a really good point, isn't it? That we're one part of understanding this. Rua Musa has given us a really good sense check. She says, well, these recommendations are already good, but they're quite hard to sometimes enact in practice, like accessing HPV vaccine from a GP outside of the national timeline. So, Joella, you're good at knowing how to get people to do things. What are your suggestions?
I work apart. That's what we have to be able to do here. But I think it's opening the lines of communication as early as possible. So it's not a case of, the patient's going to have an anti-CD20 starting next week. We need to vaccinate them yesterday. But actually start those discussions. We are trying to work with our trust public health colleagues to have the vaccine available on our unit to be able to vaccinate locally. The GP action, work to rule action, we were not allowed to call it a strike, did cause issues locally about people vaccinating people. So we're trying to ensure that we can try and work something going forward. Obviously, that's been resolved, but obviously we're not seeing the fruits of that labor yet. But it speak to your public health colleagues within your trust, because not the only people struggling with this. Like other specialities are struggling getting patients vaccinated pre-starting immunosuppression. So actually, but it's just because the way the budgets work between public health, etc., and the rest of the NHS, that's why there are difficulties. But we have limited numbers of vaccines available on our unit, which we do try and use. We did have one GP that advised patients to go and get them privately, which we just said that wasn't appropriate, because that a choice of your DMT should not be on your ability to pay, and that's the sort of fundamental ruling of the NHS. So we didn't want to go down that route.
If I can add to the answer, then now it's easier as you only need one dose. And I just wanted to mention that if you miss the opportunity to vaccinate before starting the DMTs, you can still offer the vaccine while on the DMTs. Even if the vaccine response may be reduced, some protection is better than non-protection. So.
And that's for the HPV vaccine you're thinking about.
HPV specifically, yeah.
Perfect. So our next attendee is a really good point. So says, why are DMF with normal lymphocyte count, teriflunomide, and natalizumab considered immunosuppressive brackets, and so to avoid live vaccines?
So it's mainly because of the risks. So DMF comes with a risk of lymphopenia. So especially if the patient is at risk, you shouldn't offer live vaccines. Then for natalizumab, it's not like a proper immunosuppressant. It causes immunosuppression like compartmentalized in the CNS and the gastrointestinal system, but not like systemically. So for natalizumab specifically, is more related to the risk of driven by the type of viruses. So mainly herpes viruses, which are neurotropic. So they are specifically neurotropic. So there is an increased risk of neurological complications if you get this infection. That's why, based on this risk, we sometimes prefer to label natalizumab as an immunosuppressant and be more cautious in terms of vaccines.
So that's our answer for natalizumab, although you did present some data to suggest that under certain circumstances, it may be safe. And they also ask about DMF with a normal lymphocyte count, but you sort of covered that in a bit in the live vaccines in your talk, didn't you? Saying that would you consider DMF with a normal lymphocyte count to be immunosuppressive for a live vaccine? So,
I mean, I wouldn't, and I will vaccinate the patient as long as the lymphocyte count is normal.
And it appears, doesn't it, in your presentation, you showed that there's DMF appears in 2 boxes, safe and unsafe. So presumably that's related to lymphocyte count.
So there should be a star sign saying that it's only when lymphocyte counts.
Yeah, in the full paper, it's got that. So it's a really good point, isn't it? Anonymous attendee. That's really good. A similar question, Joella. Some GPs are refusing to initiate hepatitis B vaccines. How do we get around this?
It's education, and I think a lot of it is everyone working in health services across the world feel overworked, so people are just saying no to what they can say no to. So I feel for the GPs who feel like we're passing work on to them, but it is part of their contract to vaccination cover, etc. So it is working locally, but get a scale of the problem. Like, it isn't unique to MS services within neurology, or it isn't unique to neurology, and then get the conversation locally. And it could be that actually you can look at using locally community pharmacy, etc., to sort of address some of these issues. It is a difficult one, and it's a standing one. Sadly, we're not going to solve it in the next 5 minutes on this webinar.
Okay, so reminding yourself that GPs do have a contract to deliver vaccines, but also being creative with other services and kind to your GP colleagues. Next is quite a complicated question, but this Saul is thoughts on live vaccines in breastfeeding mothers on anti-CD20. So this is, I presume this is about live vaccine to the baby of a breastfed baby whose mother is taking ocrelizumab or ofatumumab.
This is like a very specific situation where mothers have received ocrelizumab, and then babies can have like low B cells counts. And then the current recommendation is for those babies to not receive live vaccines until the B cell counts go back to normal. And then in terms of breastfeeding, the only thing that comes to my mind is the contraindication of the yellow fever vaccine, because there are some case reports on yellow fever related encephalitis in the babies. So that's another thing you need to keep in mind for mothers who are breastfeeding. The yellow fever vaccine is not recommended.
Yeah, so they've clarified things. It's whether we give a live vaccine to the baby. I'm not sure that's something that adult doctors, I mean, I think I'd ask a pediatrician, I think.
Yeah, I mean, for the first part of you will have to get in touch with the pediatrician.
And there is a caveat also, if you get exposed to ocrelizumab or ofatumumab during pregnancy, you are supposed to contact a neonatal advisor about when to give the vaccines. And I do have a friend who's a neonatal advisor, and they do this. So there is a service that will help you with this, rather than
absolutely
Joella and Saul. trying to recall our children's neuroimmunity. Next is, can a patient have a single dose of a shingles vaccine, then start their DMT, and then have the second vaccine so they don't delay things? So this is for the shingles vaccine that it's Michelle Meehan's asking. So can they have their first and then actually start on the disease-modifying therapy, because that first one's going to do the most, and then have the second?
Is this one for Joella or me?
For you, Carl, for you.
For me, I mean, absolutely. Everything is possible. It will depend, I will say, on the risks. So if you have a patient with a very high risk of recurrent herpes infections, then you will consider it to actually vaccinate as soon as possible. But then the most important thing is always MS and how active is your MS. So if there is an urge to start disease-modifying therapies, you can give just one dose and then sort of find a time window to give the second one, like increasing your chances to get like a good vaccination response. This one, again, is not contraindicated because it's the recombinant and inactivated vaccine. So you are sort of flexible in terms of safety, but you can do it. Yeah.
Yeah, you're allowed to, aren't you? And it depends on the clinical setting. It sounds, in a certain context, to be a really smart way of doing things. We've got 2 more minutes. Next is someone asking about VZV screening. So they said they're understanding that VZV screening isn't suitable for people who've had the vaccine, just for people who've had virus where they've gained immunity. So I suppose if someone comes to you and tells you that they've been vaccinated against VZV, do we still need to check the serology, or is a vaccine sufficient?
I guess this is because of, I mean, it's more reliable like having like a medical record when you can actually confirm that the patient received a complete course of vaccination. For those people who have had the disease, you don't even know if that was actually the varicella infection, you know? Like, yeah, if you don't have like a reliable proof of infection, let's say that it was documented in your medical records, or reliable proof of vaccination, you should test those patients definitely.
Okay. Young patient on natalizumab with, and we'll probably do this as our last one, but then we'll work behind the scenes to answer the rest of your questions. So we've got a young patient on natalizumab with no VZV, IgG, or evidence of chickenpox infection in childhood, and they want to switch that person to a CD20. Do you advise live vaccine on natalizumab before switching, and the gap between the dose and the second dose before starting the anti-CD20? So this is someone on natalizumab, but they haven't had a VZV vaccination, and they haven't had chickenpox infection, and presumably their antibody is a negative. So do we inject them with VZV whilst they're on natalizumab, or do we do something else?
This is a very tough one.
It's good questions, aren't they?
Yeah, but you know, like giving the accumulating evidence on the use of live vaccines and natalizumab,
Yep.
I will say that it will be less risky to vaccinate the patient on natalizumab.
I think that showed really well, didn't it? And hopefully that gives us information.
Yeah. We even for the ECTRIMS consensus, we even consider to include like switching to natalizumab or starting the patient on natalizumab when there was like a strong consideration on the use of live vaccines, but that will be extremely rare, and not all the participants agree with that because of the lack of good evidence. So we remove it from the final recommendations.
So I have to draw things to a close. So thank you, everybody.